Good afternoon, everyone. Thank you for joining us. Welcome to the National Center for Youth in Custody webinar series, What Works? A Practitioner's Response to Theory and Evidence. Our webinar today is titled Trauma-Informed Care. And throughout this 6-part series, we will be presenting strategies that meet the standards of evidence-based practice, evidence-informed practice, and evidence-based decision-making, definitions and explanations of which are included in the handouts that you will find with this webinar. My name is Natasha Martinez, and I am a program associate for the OJJDP National Center for Youth in Custody, or NCYC. NCYC is a national training and technical assistance center created by the Office of Juvenile Justice and Delinquency Prevention and coordinated by the National Partnership for Juvenile Services. The National Institute of Corrections also serves as a partner with the center. We are so very pleased to have you with us for what will be an excellent and informative presentation. This webinar is the first in our series on incorporating data and research into programming and care in juvenile facilities. Before we begin, I'd just like to address 2 housekeeping matters. First, this webinar is meant to be interactive, and we encourage everyone to submit any questions you may have throughout the chat or throughout the presentation using the chat function on your screen. Following the panelist presentations, we will have a question and answer period, during which time we will address as many of your questions as possible. You may submit questions at any time during the webinar, and we will compile them to address them afterwards. Second, at the conclusion of the webinar, we would appreciate if you could stick around for just a few seconds to complete a survey on the presentation. The survey will pop up automatically when you exit the program, and having your feedback is vitally important to us as we plan for future webinars and training. Make sure you stick around at the conclusion of this webinar for more information about what's coming up in our webinar series. Before we begin the webinar, staff with the National Training and Technical Assistance Center will go over some of the more technical aspects of today's presentation. Callie?
Thanks so much, Natasha. Good afternoon, everyone. My name is Callie Long Murray, and I am with OJJDP's National Training and Technical Assistance Center. As your host, I would like to take a couple of minutes to discuss a few features of Adobe Connect, which will help you maximize your opportunity to participate in today's webinar. To view the bios and photos of the presentation panel, please access the PDF documents, which are now available in the handouts pod of the webinar dashboard. To send a chat message to me, your host, a panelist, or another attendee, click the menu icon in the upper right corner of the chat pod. Choose Start Chat With, then select Host, Presenters, or Specific Attendees. Type your message into the text box, and then hit Enter or click the message bubble icon to send. For those of you participating in today's webinar as a group, please take a minute and help us count. Go to the chat window and type in the name of the person registered and the total number of additional people in the room with you today. This will help us with our final count. If you're viewing by yourself, there's no need to type anything. Once again, please type the name of the person registered and the number of additional people joining you today. As Natasha said, at the conclusion of today's webinar, you'll be provided with a link to take a 5-minute online survey about today's presentation. We appreciate your feedback regarding this webinar. Lastly, this event will be archived in OJJDP's online university at www.intac.org in approximately 2 weeks. You can also check out past webinars by NCYC that have been archived on the online university. They have presented some great information that we are happy to share with you, so please access these important resources at your convenience. Again, thank you for joining us today. I will now turn it back over to Natasha.
So today, the panelists will present on trauma-informed care, one of the priority areas identified by OJJDP Director Robert Listenby. When we researched this topic, as we were preparing for this webinar, we were able to identify different levels of trauma-informed care depending on the provider, the recipient, and the types of services. Today, we will look at 2 levels of trauma-informed care, trauma-focused and trauma-informed. While trauma-focused care targets a particular individual and is typically more attainable in facilities with clinicians who can assess and create individual programming, it also includes all of the organizational, cultural, aspects of trauma-informed care. Trauma-informed care is about your relationship with youth and how those relationships play out daily and over time. While not all facilities have the resources needed to provide trauma-focused or trauma-specific care, all facility staff can interact with youth in a manner that is trauma-informed. Today's webinar will provide training and testimonial to the use and success of trauma-informed care. The webinar will explain what trauma-informed care is and how to begin implementing it in your facility, as well as what is currently being done in trauma-informed care facilities, including staff's observations and success rates using this approach. Specifically, we will focus on being able to define trauma, being given fiscally responsible, practical ideas on how to create a trauma-informed environment within a secure juvenile justice setting, understanding the potential operational challenges of incorporating trauma-informed principles in a juvenile justice setting, and then how to address them, understanding the importance of ensuring resources are available to staff during training, and describing how applying the principles of trauma-informed care will benefit both youth in the juvenile justice setting and those who work with them as well. We're going to open the webinar by giving everyone the opportunity to hear from Dr. Gladys Negron and Dixie Fossler. Dr. Negron is the Regional Director, Detention Services South Region for the State of Florida Department of Juvenile Justice. She has been involved in the juvenile justice arena for over 21 years and previously served as part of the executive leadership team at the Miami-Dade County Juvenile Assessment Center / Juvenile Services Department, where her duties included coordinating 30 nationally recognized researchers during the implementation and coordination of the National Demonstration Project, the internationally recognized reform of an active, functioning juvenile justice system. Dr. Negron received her doctoral degree in clinical psychology as well as a master's degree in clinical psychology from the Miami Institute of Psychology in Miami, Florida. She also holds a master's degree in mental health counseling from St. Thomas University in Miami, Florida. Dixie Fossler is the Regional Director, Detention Services North Region for the State of Florida Department of Juvenile Justice. She's been involved with the juvenile justice arena for over 28 years. She has worked in several detention centers across the state, starting out first as an officer on the floor. She was most recently the longest-running superintendent in the state at Marion Juvenile Detention Center, where she served as superintendent for 19 years. Her experience includes transforming Florida's first trauma-informed care detention facility, and she has been instrumental in promoting trauma-informed practices throughout detention services and facilities in the North Region. She is a graduate of St. Leo University, where she earned her Bachelor of Science degree in criminal justice. She then earned her master's degree in management from Webster University out of St. Louis, Missouri, and graduated summa cum laude. We will also hear from Dr. Joe Tomasone. Dr. Tomasone is currently serving as Acting Associate Commissioner for Youth Programs and Services for the New York State Office of Children and Family Services Division of Juvenile Justice and Opportunities for Youth. In addition to individual facility clinical oversight, he is responsible for developing mental health policy and programming for the Bureau of Behavioral Health within that division. He is the principal author of the New York Model, which revises and reconceptualizes the delivery of services to juvenile justice-involved youth throughout New York State. The New York Model is a trauma-responsive program which uses relationships between youth and staff in the context of an entire community of supportive people and systems to promote the use of skillful and effective behaviors to assist youth in reaching self-identified goals. Dr. Tomasone received his PhD in clinical psychology from the University of Rochester. While at the University of Rochester, Dr. Tomasone's graduate research was in the area of intrinsic motivation and the parenting of special needs children. He trained at the Child and Adolescent Psychiatry Clinic at Strong Memorial Hospital in Rochester, New York. Dr. Tomasone is a licensed psychologist in New York State and has over 25 years of experience working with children, adolescents, and families. As you can all see, everyone that is speaking today is more than qualified and has a wealth of knowledge to share with us. So without further ado, I'm going to hand it over to Dixie and Gladys to start.
Hi, good afternoon. This is Gladys, and I'm going to go ahead and start. And today we're going to focus on individuals and families being provided the opportunity to live with more hope than fear, receiving the right services at the right time for the right child. Providing child-centered, family-focused, gender and culturally sensitive, community-involved, and outcome-driven trauma-informed services are a pivotal focus of the Florida Department of Juvenile Justice. Trauma, by definition of the National Association of State Mental Health Program Directors, is the experience of violence and victimization, including sexual abuse, physical abuse, severe neglect, loss, domestic violence, and/or witnessing of violence, terrorism, or disasters. There are different types of trauma: acute, which is a single event that is limited in time; chronic, which is the experience of multiple events; complex, which is the exposure to chronic trauma and the impact such exposure has on an individual; and system-induced trauma, which is the traumatic removal from home, admission to a detention or residential facility, or multiple placements within a short period of time. When dealing with trauma, remember to be cognizant that protective factors may exist for particular youth. Protective factors are conditions or attributes, skills, strengths, resources, supports, or coping strategies in individuals, families, or communities that help people deal more effectively with stressful events and can mitigate or eliminate risk in families or communities. So, don't ever take down a fence until you know why it was put up. Trauma can occur from accidents, serious incidents, emotional, physical, sexual abuse, losing a loved one, being in a hurricane, a flood, or another natural disaster. Exposure to trauma, as mentioned previously, can be a single event, connected series of events, or chronic lasting stress. It could occur at any age, affects any race, any gender, ethnicity, socioeconomic group, community, or workforce. It's important to realize that trauma is an individual's experience of the event and not necessarily the event itself. Protective factors, as mentioned previously, include social connections, parental resilience, concrete support in times of need, nurturing and attachment, and social and emotional competence of children. At this point, I'm going to hand it over to Dr. Tomasone.
Okay, thanks very much, Dr. Negron, for that important and grounding discussion that gets us started on the same page. And a quick note of thanks to NC4YC for the invitation to participate in what's clearly a really important and ongoing discussion about trauma-informed programming in the juvenile justice setting. So I've been asked to provide some practical implementation ideas and tips from an academic and even philosophical perspective. So if you can swallow that oxymoron, then we'll be in good shape. So what I'd like to talk about is the context in which we've done some really, I think, important work in New York State. And I want to start by, again, talking a little bit about the grounding of the work that we've done, or the work that we all do across the country. We could have a whole webinar to talk about the different pressures and stressors that have been exerted on the juvenile justice system across the country, but in general I think what we've seen is that juvenile justice systems are shrinking. As a result of that, the remaining youth who are being served by our systems, particularly the residential service systems, are very high needs youth that are complicated kids who come from complicated situations. They have lots of additional needs in mental health, substance abuse, and other areas. And in addition, again, I don't think this is unique to New York State, resources are limited in juvenile justice service settings. So as a result of that, I think we have to start by acknowledging that there are high levels of stress in the juvenile justice systems for both youth and for staff, and you'll see in a minute why we include that as in the conversation. It's not unusual to see poor compliance of the kids in the system and poor engagement in programming, and it has an impact on staff. Low morale, high rates of workman's comp, high levels of call-ins and injuries and other sorts of things. Another side effect of all the stressors on the system is that people may rely overly and heavily on use of physical force as a behavior management tool, or use of isolation and confinement as a behavior management tool, which we all know has extreme negative impacts on youth. And then again, just from a very practical point of view, high levels of staff and youth injuries, which are just unacceptable in our systems. So the goals and the challenges for a therapeutic or trauma-informed care environment is to provide juvenile justice residential care services and supports to an increasingly smaller but increasingly complex and challenged population. So you may have only a handful of kids left in your system, but they may be the most difficult kids to program for and the most complicated kids to understand. You know, part of it is that the goal is to create and maintain both emotional and physical safety for both youth and staff. And again, you'll hear me saying that fairly frequently during my part of the presentation, because we very strongly believe in New York that what we do for our kids, we have to be willing to do for our staff, especially when it comes to the issue of trauma. Obviously, we want to reduce the use of harmful physical interventions, reduce the use of isolation and confinement, and we want to be able to address trauma quite straightforwardly. And again, we always talk both about the trauma to the youth that we serve and the trauma to the staff who have been serving them. So some more discussion of the goals and challenges. We want to meet the therapeutic needs of this increasingly complex and multi-challenged population of youth in care. Again, we're finding, and I presume that it's not unique to New York, that the kids in our care rarely have one single sort of focused set of problems. It's usually lots of different things going on that include family issues and individual youth issues. So the real task becomes, how do you change your organizational culture? How do you change your system from what may have been a focus on custody and containment and a focus on safety via custody and containment to a focus on treatment? Safety, again, via authority, rules, limits, restraints or isolations, to focusing on safety via relationships. And that's a big jump for a lot of people. And what we have found is that you really have to let people know how it makes sense for them to make that jump, because initially it might feel quite unsafe to move to a more therapeutic focused system. And we'll talk more about that in a second. And again, another part of this cultural shift is from focus on youth as individuals to youth in their context, the context of their family system, the context of their community, and in their own sort of skin, their own unique context. It's very important not to try to do this work alone, and that's part of what we've done in New York State, is to draw in as many helpful people as we possibly could. So trauma-informed care, how do we define it here in New York? We talk about using an awareness and understanding of trauma and to guide decisions about programs, services, interventions, policies, and procedures. So we want trauma, an understanding of trauma, how trauma occurs, what the impacts of trauma are, how people react when they're traumatized, to inform all of our decision making. And that's really important because, again, what's good for our kids in care is good for our staff members as well. So when we train this in New York State, we train all levels of our administration right up through our commissioner. So it's very important that everybody's on board. Trauma-informed care strives to help people recover from previous traumas and then also reduce and eliminate new traumas. So you have to look at your system and look at the places where you may be reinforcing previous trauma or reactivating previous trauma or creating new traumas. And you have to sometimes be brutally honest with yourself, and that's not always an easy thing to do, but that will create true cultural change in your system if you're able to be honest with yourselves about how your programs operate, and really help and support people in understanding why this change is so important for them. So if you could for just a second, imagine a person who has trouble trusting other people, spends much of their time feeling fearful and apprehensive. Maybe they startle easily, and then when you startle them, they respond, instead of with surprise or fear, they respond with anger and aggression. That then takes the form of seemingly being without provocation. They don't plan very well, they don't think about the future, they don't work toward goals. Again, this person might be outwardly impulsive, disorganized, aggressive, but they're constantly on alert, emotionally and physically. And again, some of the other presenters are going to talk more about how trauma affects people. Understanding trauma means being able to look beyond what you see on the surface and avoid misinterpreting a particular behavior. So the easy example is, you brush by a kid who's in program and they flip around on you abruptly and they raise their fist. That in and of itself might seem quite odd and unpredictable, but if you consider the possibility that maybe this kid has been significantly traumatized over the course of their life, that behavior starts to take on a different meaning, and then you can approach it differently. So instead of labeling that kid and thinking of that kid as an impulsive, aggressive kid, you think of that kid as a traumatized kid, and then you understand how to approach that kid in a very different fashion. And you're not just managing a behavior, you're understanding a behavior in the context of a problem that needs to be addressed. So again, some of our foundational concepts here in New York State that I think are really important is that trauma-informed care is for everybody in your system. Everybody's subject to trauma. Again, and so we talk a lot with our staff about the trauma that they've endured as part of the changes in our juvenile justice system. And again, I think those changes are similar to changes that other jurisdictions have had and other states have had, but also their personal trauma. And again, we don't so much get into that, but people need to be aware of that. People need to be mindful of their own personal histories and how it relates to their ability to do this kind of work. Parallel process is a concept where things that are going on for the kids are often generated from and related to things that are going on for staff. So we talk about a transactional model where changes in one system, like the staff system, has predictable changes in the youth system. So you can't change one set of variables and not expect there to be a change in the other set of variables. And that's something that, again, when you talk about it and you put it in this context, it makes sense, but we hadn't often thought about that previously, and so it's really important that that's a focus of our ongoing work here. So again, I apologize for being repetitive, but it's such an important concept in our system. What's healthy for youth in care is also healthy for staff, and the flip side is also true, that what's harmful for youth in care is also harmful for staff as well. So we want to be mindful that our system, we want to create a healthy system for everybody in it. And again, the commitments to a therapeutic or a trauma-informed system of care need to be inclusive of the highest levels of administration. You can't break it off and say, okay, from this level down, we're going to be trauma-informed, and from that point above, then we're going to do business as usual, and we're going to punish people, and we're going to be judgmental of people, and things like that. That's not going to work, and we've experienced that, and we know it doesn't work, and I think the literature also supports that. Another foundational concept, and this is really important as you talk to people about changing from a system that's more sort of safety via rules and regulation focused to safety via relationship or therapy focused, that safety is a precursor to change. So if you don't feel safe, you're not going to make changes. And that's true, again, for kids as well as staff. If staff don't feel safe, they're not going to change how they work with kids, and if kids don't feel safe, they're not going to change their behaviors. Obviously, you have to consider safety as more than just physical safety. It has to include emotional and psychological safety, and this is an important concept, I think, for staff, that safety requires clear boundaries, clear expectations, clear consequences, which result in clear and consistent structure. The issue is that staff initially, when you start talking to them about creating a treatment-focused environment or a therapy-focused environment, they get concerned that it's going to be chaotic. They get concerned that rules and regulations are going to go out the window and that accountability goes out the window, but quite the contrary. In order to have a therapy-focused setting, you have to have safety. In order for you to have safety, you have to have clear structure. And so the idea here is that more knowledge and more awareness of the factors that apply to the kids in your care give you more tools. So you don't want to fall into the trap of staff saying, well, you're taking away my tools. If you're focused on therapy and not allowing me to do restraints, or you're discouraging me from doing restraints, you're taking away one of my tools. And what you really want to help people understand is the more you understand trauma, the more opportunity you have to work with a kid that doesn't involve a physical intervention. So you're in fact developing way more tools. New understanding creates opportunities for creativity and flexibility. It's really important that that people are allowed to use their knowledge and experience. We have a lot of people in our system, and again, I assume across the country, that have an incredible wealth of knowledge, but feel stunted by the philosophy of the agency or the rules and regulations of the agency. And we want to take the lid off of that. We want to help people be creative and flexible while they're being safe and while they're being trauma informed. But you want to open that door and let people do what they're good at. A trauma-informed system of care adds to their toolbox, not detracts from it. So how might you go about this? One of the things is that you might create a master action plan, a very detailed idea and set of expectations for your system, but you need to do some self-assessment first. So you need to look at your current status, you need to look at your current needs, the kind of kids you're serving, and your current resources. What do you have available to you that you can utilize and bring to the table? And this is where you need to be, this is the immediate point where you start thinking outside the box. Okay, I have a limited number of staff, I have a limited number of clinicians, I have a limited number of administrators, but maybe I have some community resources that I can bring to bear. Maybe I have some people from the community who I can bring in and utilize either in a volunteer capacity or in a per diem fashion to provide some services or provide some consultation. You also have to decide what kind of programming you want or need. Trauma-informed is a really good idea so that everybody in the system is aware of how trauma impacts people and is sensitive to those issues. We like to call what we do in New York trauma-responsive programming. So we actually add a treatment component, which involves some cognitive behavioral therapy to go beyond being sensitive to trauma and actually trying to address it in a treatment-focused fashion, and that involves a whole different set of ideas and needs and resources. So you really have to decide what your goal is, and then you can get some information about what you need to do to actually fulfill that goal. Another thing that we learned and would strongly recommend to other folks who are doing this is consider starting small. Depending on your system, you might start with one facility if you have several, or you might start with one unit within a facility if you have several units within a facility, because what you want to do, and this is twofold. So one is it's easier to manage change when you're managing it on a small scale and you have a limited number of players who are involved. But the other thing is that part of it is for lack of a better term, trying to sell it to people who are going to be doing it in other locations. So if you can create a demonstration program where they can see that some of the ideas and concepts that you're using actually work, then it's an easier sell. People can visit the program, people can talk to the people who are actually doing the work, and that becomes a demonstration or a model program within your system. You obviously want to take a look at your stakeholders, both your internal and external stakeholders. Again, you want to cast as broad a net as you can. We ask ourselves constantly when we're talking about resources or we're talking about groups of people getting together to make a decision, who are we missing? Who are the people who should be at the table? And there's a lot to do, so there's lots to delegate. Make sure that you're being inclusive of all the people who can support you. And you always want to include youth and families. Again, that's really critical, and it sounds silly, but when we looked internally at our system and looked at the history of our system, we were amazed at the amount of decision making that happened without the input of youth and families. And so it's really important to rectify that and make sure that they have a voice at the table. As will your staff, as will the other folks that are providing the services. So An example of the internal stakeholders would be your staff, your facility administrators, if you have a central office that administrates your programs. In New York State, we have unions, so we have a unionized labor force, and they have to be at the table to talk about some of the changes that we want to make. We have a legal department that we consult with on a really ongoing basis about the changes that we make to make sure that we're supported with statute, both in New York State and federal statute. And then again, the other important internal stakeholder are your youth. External stakeholders, and again, they're sort of an internal external, but family members. Youth advocates, people who make it their career and their business to understand the issues that occur for kids in care and articulate them. They're important members of your external stakeholder team. Community partner programs, and again, this differs depending on your location and the relationships you have with folks in the community, and then your communities that are served. So if you have facilities that are in particular locations, again, you want to tailor this so that it might look slightly different at different locations depending on the resources that you have available. And you want to be flexible. You don't want to try to have a system either for the kid or for the facility that's one size fits all. So as you do this, you really individualize not only the care for the youth, but the support that you're offering to the administration and to the facilities. So we have a couple of principles, may not be the best word here, but some implementation strategies. That's maybe a better way to say it. And I'm going to go through, and I apologize, I'm going through fairly quickly because I know we have limited time. Some of the implementation strategies that we've utilized here is to create an infrastructure of licensed mental health professionals. And they're there to provide assessment and guide treatment planning. So in our system, we hired a lot of social workers and psychologists and some psychiatrists in various permutations. So we had some full-time folks, some part-time folks, some contracted folks. We partnered with our sister agency in New York State, which is the Office of Mental Health, and we also partnered with some community providers. The reason for that is you want some expertise in your system to guide the planning and also to do a lot of other sort of auxiliary function as you transform your system to trauma-informed care. I recognize as I say that most jurisdictions don't have a big pot of money that they're sitting on to hire a bunch of people and bring them in, but this is where you have to be creative, and you might have to hire a limited number of people who go around and do your consultation and do your some of the work. In our system, we created some hybrid positions who are clinical administrators. So they have the sort of administrative authority in a facility to make real-time decisions about child care, but they're licensed and trained mental health professionals who come at their job from that perspective. And we also had some enhanced line staff and case management providers. And again, we had some unique circumstances in New York that allowed us to do that. I recognize that a lot of jurisdictions don't necessarily have a big pot of money, but it's important to figure out how you're going to get some of this expertise into your system. Excuse me. And then, perhaps ironically, we then, after we hired all these mental health folks, we then try to demystify their existence. So we don't want a system where the mental health professionals are considered to be sort of magicians where they can take care of problems and make them go away. Rather, they're there really to provide support and consultation to the people who really provide the most critical work with kids, who are our line staff. Line staff know our kids the best. Apart from their families, they know the kids the best. They spend the most time with the kids. Their input into our programming is really important. And we create support teams of people who come together to provide the services to kids. And we want them to have an equal voice to any other member of that team. So it might be a psychologist, a psychiatrist, a teacher, an administrator, and a line staff talking about a kid's progress, and everybody in that system has an equal voice. We really want our line staff to own the facility environments, and by that we mean that they feel responsibility and ownership, and they take pride in their environment. So We want our line staff to be concerned about not only the physical environment, sort of the cleanliness and safety of the environment, but also the emotional environment. So when you walk on one of our units, we want our line staff to, to talk to you about how they take responsibility for the unit, how they promote the well-being of the kids, how they are involved in the treatment, and they are knowledgeable about each of the kids in their care. Again, the care issue is not something that happens with only the licensed professionals. It happens, everybody in our system is a provider of care to the kids that we have in our system. The third of the ideas, strategies, or principles is to create and expand the idea of community so that people aren't making decisions in isolation and people aren't making decisions alone. We want everybody who interacts with a kid in our system regularly to be a part of their support team. So that involves a lot of technology solutions like using video conferencing and telephone conferencing, but we really want to pull in as many people who are invested in a youth as possible to provide support and service and intervention to that particular kid. The youth and family set the goals in our system. So we used to have a system where we prescribed goals to a kid, and we would say to a kid, you should get a GED, or you should take the carpentry program, or you should go into auto mechanics, and we don't do that anymore. So we now say to the kid, what are you really interested in? What is it that you're interested in doing, and how can we help you get there? We end up with the same package of services because the obstacles are the same and the challenges are the same for each kid, but we come at it motivationally from a very different place when the kid is able to say to us, this is what I want to do. And then we try to help them get there. So it's all about creating the team and working as a team so that people aren't on their own. And the last of these strategies that I want to talk about real quickly is individualizing the plans and programming. Again, when you start with a youth-generated goal, it almost guarantees that you're going to end up with an individual plan because every kid is so different. Even if two kids have the same goal, they're going to come at it completely differently because they're going to have a completely different set of assets and they're going to have a completely different set of vulnerabilities and obstacles. It also, again, in our system, it serves to reduce the power struggle. So rather than trying to get a kid to do what you want them to do, you're aligned with the kid to try to get them to do what they say they want to do. So when there's a problem and when there's a circumstance that goes awry, rather than you saying, well, you broke the rule of the facility and that's a problem and we're going to give you consequences, you say, hey, you're a little bit off track from the plan that you say you have. Your plan is to go home and get a high school diploma or go home and get a job, and when you break the rules, it keeps you from going home. So we don't own the problem, we don't own the solution. We hand it over to the youth and to their family. And I think that's an important component of trauma-informed care, that people don't create the trauma in their lives and they don't create the results of the trauma in their lives, but they have to be involved in solving those problems. They have to be involved in the resolution of those problems. So it's really important that we not take that responsibility away from them and that we empower them to make those changes themselves. So how do you do this? One important component is that you're going to do lots and lots and lots of education and training. So staff need to understand why they're learning it. They need to understand why you're hitting them with this information, why you're going in the direction that you're going. So you should be prepared to explain it to them. They need background information on trauma, mental health, substance abuse, adolescent development. So they need a package of information that's going to give them a good context to understand why you're headed in this trauma-informed care direction. They also are going to have some self-reflection. They're going to have to be able to look at their own beliefs and their own assumptions and their own issues. And you may find at the end of it that some staff say, this isn't for me, this isn't what I signed up for, this isn't how I thought I was going to be doing my job. And that's okay too. This isn't about being judgmental, but about matching up the right people with the right positions to help the kids in the way that they need to be helped. And education and training is never going to be a one-shot. It's always going to require boosters, repetition, reminders, and you probably want to build that into your system in terms of your meeting schedules and reminding people about training components and training initiatives. You can build it in so that you do a little bit of training all the time rather than doing a lot of training in big chunks. But you want staff to use their understanding, their increased understanding of trauma and adolescent development and all the other issues that you're going to talk to them about to apply to the kids in their care. And they need to know about the kids in their care and make the connections to the training and then the understanding of what they've what they've learned and then give them opportunities to respond to kids differently. The more they understand the kids that they're taking care of, the more opportunities they have to respond differently and meet the needs of the kids who you have. In our system, and maybe this isn't unique, we train our staff and our kids together often. So if there's a new initiative or a new topic, we train kids and staff together. And we think that's a really important message to kids, that what we're saying to kids is, look, this material is so important that I'm sitting here next to you learning it while you're learning it. And we can ask questions together and we can clarify it together. And it really does, I think, create a sense of community among staff and among the kids. We also feel real strongly about having intact teams. So on our units, on our residential units, we try to keep staff consistent. So it's the same set of staff every day, and it's the same set of kids every day. So it's tempting when a kid has a string of behavioral problems to move that kid to another unit, or move that kid to another facility. We try to reduce that because that's a healthy model, right? That's the family model. You don't kick a kid out of your family because they're struggling. You actually envelop them with supportive people and try to help them work through the problem. So we try to model that for staff and, again, model that for kids as well. So we try to avoid the geographic solution. I'm speeding up a little bit because my time is waning here. Another how in this whole trauma-informed care implementation strategy is you're going to use structure as a way, and organization as a way to implement your trauma-informed care. So again, we use this idea of ownership for space and responsibility for space and pride for space, whether it's a kid's individual room or the unit that the unit is responsible for, or the unit that the staff is responsible for. So we want people to feel comfortable in their space. We want them to take responsibility for their space. And we use it as an indicator of how people are doing. If we walk on one of our units and there's a mess that hasn't been cleaned up for 3 or 4 days, that's a red flag to us for something that we need to get on. So again, I'm going to speed up because I apologize. I have more slides than I can get through maybe in this time. Clear rules, expectations, and consequences. Again, the structure is really important. Good behaviorism is really, really important. Consistency and follow-through. So again, a lot of the things that your line staff might be concerned about going out the window when you do trauma-informed care, you want to reassure them those are actually the foundational components of trauma-informed care. We use a lot of groups, so we bring kids together, we teach skills. Some of it's psychoeducation, so people need the background information, the kids need the background information in how trauma has affected them, but then they also need skills to resolve the issues that result from the trauma. And those groups are run by our line staff because we want them taking responsibility for the treatment as much as possible. Some of your procedures you're going to want to look at, again, some different ideas that I won't get into a lot of detail here. I'm running out of time, but we can talk about in the question section, or we can follow up afterwards. But how you do your procedures and your processes, you really need to look at in terms of how it supports your trauma-informed care or how it doesn't support your trauma-informed care. Language matters. How you talk about the things that you're doing and the language that people use in your system is really important. So we reconceptualize the idea of supervision because in our system, supervision had a real negative connotation. I've heard of an agency where one of their units was called the projects, and that just really is reflective of the attitude of the folks toward that particular unit. And you have to be mindful if people are calling your kids youth or residents or students or inmates. Those are very different uses of language and really reflect your programming. I am now out of time, so I'm going to look at. I'm going to whip through these last. I have like 2 more slides, so I'm going to whip through them. Some of the challenges are staff resistance, staff inertia. This is how we've always done it. You have to be prepared to talk to them about why this is in their interest and how this is going to benefit them. And again, we can talk a little bit more about that in the question and answer section. Other challenges, again, lack of resources. People disagree about philosophy. People may have a differing agenda. Your external stakeholders may have a differing agenda. And those are all things that you have to manage as a team and as a group together. And then lastly, make sure you keep track of what you're doing so that you can show some evidence that what you're doing is working. So we have a whole system of quality assurance and data collection that we collect to make sure that people are utilizing effectively what the services and supports that we're pouring into them. So I apologize for the pace toward the end here, and I'm going to turn it back over to our friends from Florida. Thanks very much, everybody.
Okay. Thank you, Dr. Tomasone. This is Gladys again. I'm going to go ahead and talk about implementing trauma-informed practices in juvenile detention centers in Florida. And that, for us, meant putting trauma-informed care into action by providing the foundations on the basics of what trauma is and what trauma represents, the psychological, the neurological, biological, and the social impacts of trauma on the youth that we serve every day. Learning and incorporating those proven practices in our current operations and delivering the services that acknowledge the role that the trauma and the victimization played in the lives of the youth that enter our system. By learning what trauma is and its effect on our youth, the principles of trauma-informed care provide a paradigm or a model, if you will, whereby services are organized and transformed from the basis of what's wrong with you to one of what's happened to you. An example of opportunity about the right to embrace a present and a future that are not completely dominated and dictated by the past. It's an opportunity for hope and a positive change. We began to look for ways to help our youth overcome triggers and the automatic behavioral responses to those triggers. And as most of you know, if all of you know, that triggers can be seen, they can be felt, they can be heard, they can even be smelled. And any of those can activate an internal alarm system and initiate a behavior that's needed for survival, and in essence they turn off that thinking brain, so much so that the past and the present danger become confused. And you all know that even as adults, we all have buttons that can be pushed, and those buttons are based on the totality of our experiences. But for trauma survivors and youthful trauma survivors, it's different. This photo will exemplify the adage that a picture is worth 1,000 words. Two adults and a youth talking is what our experience as adults might be. However, for a youthful trauma survivor, this can be experienced as two adults screaming or harshly interacting with the youth, and then the youth's resulted feelings of fear. Research and understanding of the experiences of trauma and its devastating effects on youth. The department searched and found a trauma survivor, and her name is Tony Kane. And I'm going to turn it over to Dixie now, and she's going to speak more about how trauma-informed care began in Florida.
Okay. The Florida Department of Juvenile Justice first became interested in trauma-informed care about 8 years ago. We had participated in a pilot project called Trauma-Informed Practices, and shortly after that we were introduced to Tony Kane, who is a trauma survivor. Through a series of trainings, we exposed as many of our staff as possible to hear her story, a story that made you wonder how many times I had said to a youth, "What's wrong with you?" instead of "What happened to you?" In February of 2009, members of a number of state agencies met with the National Association of Mental Health Program Directors to discuss a statewide trauma-informed care initiative. This work group went before the Children's Cabinet to share a collaboration of these agencies to interrupt the trauma cycle and provide treatment to those entrusted in our care. So how do you get started? You have to recognize that what you're currently doing may not be working. We initially gauged our success by how much we were able to reduce our physical intervention and isolation. You have to treat all youth as if they have experienced trauma, and our statistics indicate that most have. Your staff need to feel comfortable thinking outside the box. It's important to include all departments in your facility, from your officers to medical to education. Allow your staff to express their feelings. This move away from a correctional mindset can be difficult for some of them. In Florida, we have the full support of Secretary Walters and our staff. And as it was mentioned earlier, training your staff is very important. Staff need to understand what trauma is, how it may affect the youth, and how they can appropriately react to particular behaviors when they're trying to teach coping skills. One example, personal example of why this was so important, when we first started using the trauma-informed care model, we had spent approximately 6 months effort continuously training staff and trying to get feedback. We were fortunate that our mental health, designated mental health authority was licensed in trauma-informed care as well. And she helped us train our staff. And then during that time, we noticed that our physical interventions were almost non-existent and our isolations were reduced significantly. Around the end of the year, we had lightened up on our training and focus with staff. It was around the holidays. Everybody kind of laid back, took a break. By the end of January, in a 30-day period, we had more physical interventions and confinement than we had had in the previous 6 months. Continuous training and reinforcement is very important, especially in the beginning. For fiscal year 2012-2013, our 21 detention centers in the state of Florida had an average daily population of 869 youth with an average length of stay of 11 days. We focused on that captive moment that we have youth in our care to try to make a difference in their lives. Now I'm just going to go through a few slides that show some of the transformations that have occurred in our facilities. As you can see up in the top corner, that's what a room did look like. And then I'm going to flip through some slides that will show you some of the things that we changed, some of the paintings that were done. The staff painted day rooms and hallways. Some facilities even chose to paint the inside of youth rooms. And by the way, this one that you're looking at in the bottom right-hand corner, some of that was done by the youth. And these are pictures from our facilities all over the state. We have crisis rooms and libraries. And this particular facility uses a program that they call Paint a Brick. Once a youth reaches a certain level, they can appropriately personalize their own brick in the day room area of the facility. Some facilities provide sleepwear, slides, journals, a break from institutional wear and decorum. Youth are also given individualized personal hygiene items. And I'm turning it back over to Gladys.
As you can see, the department made great strides in the area of trauma-informed care practices. We now have a trauma-informed workforce. We have environmental changes, soft rooms, journals, vegetable gardens. We have life skill groups, faith-based services, family engagement, and crisis intervention for our kids. Thinking of one more innovative, somewhat out-of-the-box idea, we came up with the Detention Services Pilot Dog Program. Let me go back to Justice here. And that's Justice. He's a rescue Great Dane Lab mix that's affectionately known by the kids and our officers now as Officer Justice, or the canine officers. He's made his rounds at conferences and college classes. He began with us in December of 2012. Knowing that the success that therapy dogs had within other settings, such as hospitals, schools, airports, hospice, and assisted living and nursing home settings, we figured we'd try to incorporate a dog into detention services as another positive intervention. We set out to research based on our population, our needs and our ultimate goals. And what we began to see surpassed our greatest expectations. We saw an immediate reduction in the use of confinement and physical interventions. We saw an increase in our youth's ability to self-regulate and increase self-esteem. And some youth, for the first time, being able to just let their guard down for a moment. Not only did we do our research, but we did a lot of homework. We looked into the best breeds of canines to use as therapeutic animals, the best foods to feed the dog, how we would attend to the dog, what size of a dog we would get, what kind of exercise the dog would be involved in, grooming, etc. But the most important aspect that took place and took us the greatest time of research was researching the appropriate training for the dogs. So we took a long, hard look at the commitment and the risk that would be involved in embarking down this road, and we decided that we were going to try it. And with the never-ending support of our Secretary, Wansley Walters, and the Assistant Secretary of Detention Services, Julia Strange, we developed a plan. The only constant in the plan initially was the where. Being that we're in the South region, I figured we would start in the largest facility in my region, which was Miami-Dade Regional Detention Center. And we figured we'd be the pilot site there. We then set out to determine who'd be the handler. And in this case, the superintendent of the facility, Darrell Wolf, accepted the responsibility. We went to a rescue organization, and we selected a dog. His name was Atlas. He's now named Justice. And the only thing that was left was the how, what kind of dog training. We consulted experts. We reached out to our local animal services department. We were fortunate enough to find a local trainer, who's Miami's dog whisperer, Richard Hines, and the Dog Force One, to provide the training. We had the support of our administration and our legal department, and we began. We started out by surveying the staff. We wanted to identify any staff that possibly had a past trauma with the dog, or didn't want to be around the dog, or didn't like dogs. We identified those as well that wanted to be handlers. We initiated a questionnaire for our youth that were coming into the facility to determine if any of them had any dog traumas, allergies, or any of them didn't like dogs. We had to set guidelines and parameters for how the dog was going to be used, and reiterated over and over to our officers and our staff that Justice was an additional tool for them to use to assist with the youth. Justice clearly and quickly endeared himself with staff, the youth, the judiciary, and even our local stakeholders, internal and external, our local Juvenile Justice Board. At the same time, we prepared for the you can'ts and the what ifs. We made sure that we had daily status reports and made adjustments as needed. Very soon, the you can'ts and the what ifs, they turned into we want to and how can we. We've now expanded our programming to include workshops with the youth so that they can explore a marketable skill or develop an interest in something that might lead down to a path of a different future. Our trainers provide information on how one can become a dog groomer, a veterinary technician, even a professional dog trainer. Both staff and youth like Justice, and his presence is a daily occurrence in the detention center now. Our staff bathe him, the children bathe him, they consider him one of the team. They look for him during the day, and this gentle animal instinctually knows whether he should be running with a young man or laying down with a young woman to be softly petted. This is a slide of some of our proud and committed officers at Miami-Dade, and Justice is right there in the middle. Here's an example. We started to ask our kids, what does Justice do for you? How do you feel being around Justice? And a lot of the kids gave us little quotes like this one. How I feel playing with Justice. I have fun. He helps me take my mind off of all the bad things going on in my life. Oh, and I love when he does the tricks the trainer taught him. I find that kind of cool. Additional detention centers in the state have begun different aspects of dog programming. Some foster puppies and train them for adoption, and other sites have visiting dog programs. Each and every day, Justice, who is a certified canine good citizen, does exactly what you see him doing here. He's providing support, And as one youth said, he's my best friend. He listens to all my worries. He doesn't try to figure out what's wrong or how to fix it. He's just listening. He's providing encouragement. He's giving our youth the hope that no matter what trauma they've experienced, no matter what's happened, there's always the possibility of a brighter future. I'm headed back to Dixie now.
So in the 80s and 90s, information about risk factors and disease had been widely researched. It was clear that the risk factors for common diseases tended to cluster. However, they weren't commonly distributed among the population. So a person with one risk factor tended to have others as well. The ACE study was designed and consider to be a scientific gap in the origin of these risk factors. In other words, what circumstances or risk factors preceded these diseases. And it's one of the largest investigations ever conducted. There were over 17,000 members who chose to participate. From a treatment perspective, this information is important to know about the youth that you're treating. Obviously, many of these adverse childhood experiences coexist with trauma. This slide indicates the different adverse childhood experiences that were identified in the study. And you can see there's recurrent physical abuse, recurrent emotional abuse, contact sexual abuse, and so on. From this, a simple scoring system was set up to whereby each ACE indicator had 1 point. The diseases that you see here are more prevalent in those with an ACE score. The next few slides will give you an idea of the percentage of youth in Florida during the capture of this information that had ACE issues. And so this you can tell by what the issue is, males versus females. And then in this next slide, you can see the prevalence and the number of ACE issues per male or female. And you can see that there's very few kids that have nothing. As we began to implement trauma-informed care, one area that we discovered that needed tweaking was our behavior management programs in our facilities. It was obvious that we needed a uniform system with rewards and consequences that would encourage appropriate behavior in all of our centers. We presume that every person in a treatment setting has been exposed to abuse, violence, neglect, or other traumatic events. Again, it's important to recognize that through training or even hearing about youth trauma issues, your staff may need help as well. We ensure that staff have resource information so that they know where to turn for help. Sorry, I've got a delay in my slides. Trauma is when people live with more fear than hope. Trauma recovery is when people live with more hope than fear. And that is the end of our presentation.
Well, I want to thank everyone again for participating, and I especially want to thank all of our presenters for the wealth of information they've shared with us today. I personally had the pleasure of visiting their facilities and meeting them and seeing their programming in practice, and can personally say that it is fantastic and it's very progressive, and everything they're doing, I'm very proud to say, is a step in the right direction for juvenile justice. At this point, we're going to field as many of your questions as possible. If we don't get to your question, don't worry. We will be asking that question to the panelists and then sending out those answers to you as well. So we will be addressing all of them, some right now verbally and others coming out to you. So Dr. Tomasone, we'll start with you. we have someone who would like to know what is being done specifically to help staff deal with stress. And perhaps Dixie and Gladys can talk about that as well.
Well, I think a couple things speak to that. One is that, again, the staff, when they are trained, they're trained to apply the same information to themselves as they would be applying it to the kids. So we ask them to look at their own stress and look at their own trauma histories. We also, again, as I mentioned, reconceptualize the idea of supervision to be really more about staff development and staff support. So hopefully that previously supervisory relationship that may have focused on meeting expectations and not that we abandon that, but also becomes an opportunity to provide support for staff. When there are focused issues or problems that occur in a facility, if a facility has a group disturbance or there are issues, we will bring the staff together using we have a technology that we call the red flag meeting. It's actually a sanctuary concept where we get together and talk about it and allow people to process, and that we find through the just the acknowledgement of the stress and the trauma in the environment is very helpful in diffusing the stress in the environment. Giving people a forum to talk about it and to share with each other and to support each other is really important.
Great, and there was a couple of questions. If you guys could just speak to the average length of stay for the kids in your facilities and what you've seen with recidivism.
This is Dixie. Our average length of stays in our, and I'm just speaking to our detention centers, not our residential facilities in the state. The average length of stay is about 11 days, a little less, a little more, maybe in some places. And then recidivism isn't specifically tracked, but we know that about 60% of the kids who come in contact with our juvenile justice system don't come back to us.
Yeah, in New York State, the changes that we've made have been in our community programming and our residential programming. So the information that I was talking about applies much more to our residential programming than to detention. I'm not sure exactly what our recidivism numbers are currently, although historically we've had fairly high recidivism rates, which I think are consistent with lots of programs around the country. We certainly are involved in trying to gather information about how our current programming is impacting that, but I don't have any data right now to offer.
Great. And so, Dr. Thomason, what does trauma responsive programming look like? How are the officials trained to respond? Is it just about learning that the youth in the juvenile justice system often experienced multiple complex traumas?
It's about understanding that, and then it's about applying a different set of responses based on that knowledge. So in the example that I gave earlier, if you brush up against a kid accidentally and they turn around and they cock their fist as if they're going to punch you in the head, if you're not aware of trauma-informed care principles, you might assume that that's an aggressive kid. You might restrain them. You might call for help. You might jump back yourself, instead of, and as the folks from Florida said, asking the question, hey, wait a minute, that's a really unusual response to somebody accidentally bumping into somebody. What happened to you? It leads you down a different path. If you don't have trauma-informed care principles in your arsenal, you might assume that you just have a bunch of delinquent, sort of classically quote-unquote delinquent kids who are bad kids. And what we tell people in our system is we don't know how to fix bad kids, but we do know how to work with people who have been traumatized and who have had difficulty in their lives. So if somebody's broken, then we don't really know what to do. But if you're assuming that they're struggling and they're having a hard time, then we know exactly what to do. And that's really the blessing of trauma-informed care, is it gives you a different perspective.
Okay, so great, thank you, Dr. Tomasone. For Dixie and Gladys, there's several questions pertaining to your dog program and also the painting. Number one, can you address any tagging issues that you might have had on the artwork in the rooms? And also, for Dr. Negron, given that many youth experience trauma with dogs, did that concern you at all in bringing a dog into the facility?
This is Gladys. One of the first things that we did was the questionnaire for the kids, because of course it was a concern for both myself and the superintendent. So every child that comes in gets a questionnaire during their intake, and we ask them the specific questions. Have you had any trauma with dogs? Have you had any trauma with a police dog? Do you like dogs? Do you want to be around the dog? Do you want, are you allergic to dogs? So that's a very detailed questionnaire that we ask them when they come in, so that we know. And if they don't want to be around the dog, we most definitely do. They're not around the dog. So that was definitely a concern for us. I'm sorry, what was the other question?
The other question is for the facilities that have all of the painting, what is the tagging issue? Do you have excessive trouble with youth tagging up the artwork on the walls?
No, in fact, it was a pleasant surprise that we have very little issues with the kids. Now, the only thing they do anything to is maybe the backs of the doors, because that doesn't have any artwork on it, but there's been very little damage or scratching or peeling or anything like that in the rooms that are painted.
Right. It's a sense of pride for them to look at it, and especially those that have done and participated in it.
Great, ladies. And what training did you guys do with your staff and youth together, or is there a curriculum that you used?
I think we didn't have a specific training. I mean, we had gone to the Tony or Kane training. Dr. Julian Ford had facilitated the pilot project that we were involved in some years back, and we did go to some of those trainings. Like I said, I was fortunate to have a licensed mental health counselor that was certified in trauma-informed care, and so we went to her and said, we need to train our staff. They don't understand what trauma is and the effects that it has on kids emotionally and physiologically. Can you help us? And so she kind of did that. We started out, we did it in a group setting, and then she ended up doing staff in smaller groups. And what we found out was the staff felt more comfortable asking questions, because for some of them this is absolutely opposite of what they thought they signed on to do. So I don't know that we have a specific training. We have had some different webinars that we've all participated in. Gladys?
I agree with you, but for the centers in the South, as far as the training on trauma-informed care practices, I make it a point to go to each of my centers and to talk to the staff, empowering them and helping them understand that, as Dr. Tomasone said, that a child that reacts is experiencing something. They're not just that, horrible kid that may be lashing out, that there is something behind that, and that they need to look at every child as an opportunity to make a difference. And I empower staff as much as I possibly can. That's pretty much the crux of it.
Great. And what about when you're looking at the criminogenic needs of gang members? Does that alter trauma-informed care at all?
I'm not sure who that's directed at, but I'll jump in just to suggest that we try to I don't know if I can express this well, but needs are needs, in our system. So criminogenic thinking and gang involvement come from unmet needs. So, and again, I'm talking about a residential perspective, so it might be very different from a detention perspective, and so that's important to consider. But we do a pretty comprehensive intake. It's a 14-day intake and involves a mental health assessment, medical assessment, educational assessment. There's lots of testing that goes in on the front end and gathering of information about kids. And we try to understand behavior, and whether it's gang behavior, gang membership, or other sort of historically and traditionally criminogenic notions in the context of the kid's development, and it often leads us to the same place, which is to provide skills that allow people to get their needs met in more effective ways that don't violate the rights of others, which is sort of the tautological definition of criminal behavior. It violates the rights of other people. So the idea is if we can help a person understand how to meet their needs in a way that doesn't hurt other people or hurt themselves, like that's ultimately what being healthy is all about. What we found is that so many of our kids have trauma as a complication or an obstacle to that we had to address trauma as a system, or we weren't going to be successful.
Sorry. Great. And Dr. Thomasone, you had referred to your programming as trauma-responsive programming. What do you feel is the main difference between trauma-informed and trauma-responsive programming? Yeah, well, I think, and we may have sort of coined that term to describe what we do, and maybe it doesn't fit with other people's conceptualizations, but our thought was that we wanted to go a step beyond creating an environment where trauma was understood and respected and appreciated to where we actually treat trauma. So we have a treatment component in our system where we train our therapists and our staff in using a cognitive behavioral treatment protocol for the kids in our care. So the metaphor that we use is if you had a really bad infection and you went to the hospital, which was a sanitized and germ-free setting, that would be good, and your body would fight the infection. What we say so that's sort of trauma-informed. Trauma-responsive is then you go to the hospital, which is sanitary and germ-free, and then you get antibiotics, which is like a treatment. And so we're just adding that component, and that's how we refer to. That's why we refer to our system as trauma-responsive, because it actually adds a treatment component to a milieu. Great, and this question can go to any of our panelists. Many people feel like they're behind trauma-informed care and think it's great while they're in facilities, but as we know, juvenile justice is a community effort. Do you have any recommendations for the relationship between trauma-informed juvenile facility system and then probation field services?
Well, I can tell you that when we first started doing this, we included our probation staff in a lot of the trainings that we did, and included them in the knowledge of any of the information we might have gathered about any of the youth during the process.
Yeah, sorry to jump in, Dixie. Similarly, in New York, we have a community care staff, so it's our own sort of built-in aftercare staff who we include in all of our trainings and all of our programming. You know, the holy grail obviously is helping a kid change in their home community, which is like the biggest task that any of us could ever try to do, because it's so hard to enact change at a community level. But we do try to reach out as far as we can into the community to try to, use the same ideas and strategies that we use when they're in residential care with the people who are supporting them in the community.
And how transferable do you think these practices are for youth being held in adult facilities instead of juvenile facilities?
When we participated in the trauma-informed practices pilot with Dr. Ford, a lot of the speakers that came to talk to us initially actually came from adult facilities. If memory serves me correct, I think most of them were female facilities that they had started in, but a lot of the information that was shared had been done in an adult facility.
Wonderful.
Yeah, I think...
Go ahead, Joe.
Nope, I'm done. I'm all set. Thank you. Sorry.
We did have some interest in hearing about how addressing trauma as a responsivity issue is coupled with addressing risk and need. For example, when youth and families drive case plans, how do you train staff to ensure those goals still focus and address the criminogenic needs?
Okay, I'll jump in. I think that, and we talked a little bit about this in my section about using youth and family goals. What we find is it takes you back to the same place. So if you have a kid who's, 4'0" who wants to be an NBA player, our historical response 10 years ago would be to say, okay, what's your plan B? And that completely dismisses the kid and squashes any motivation they might have to do some really hard work. Instead, we say, okay, if you want to be an NBA player, what are the things that you need to do to be an NBA player? You need to learn how to work with a team. You need to learn how to take coaching and respond to authority figures because you're going to have coaches your whole career. You need to get out of here. You need to get out of this residential setting that you're in. So it takes us to the same places, because if that kid has, sort of criminal thinking and criminal behavior, it's an obstacle to him doing the things that he needs to do to be an NBA star. But if being an NBA star is what motivates him, that's where we want to go. That's where we'll have the conversation with him and try to take him there. And so it's really kind of flipping the notion that we know better than the kid, what the kid needs, and really letting the kid tell us through their behavior and through their choices what it is that they need. I'm not sure if that exactly answers the question, but that's how we approach it.
Great. Well, at this time we are going to wrap up. We know that everybody is busy and has planned their day around certain time frames. I just wanted to thank everyone again so much for participating in today's webinar, especially thanks to our panelists who obviously are experts in their field and are doing wonderful things with these kids. I first wanted to call your attention that the next webinar in this series is next month, and it will be held on May 28th. It is focusing on cognitive behavioral therapy, and we would love to have you join us for that webinar as well. We'd also like to have a huge thanks to NTTAC for being our technological gurus and facilitating all of this. We wanted to remind you that this webinar will be archived on OJJDP's Training Center website, as Callie had mentioned earlier before. And then just once again, we'd like to please ask you to take a few moments to fill out the survey. It really does help us in developing future surveys and making sure that we're addressing the needs of what's being needed out there in the system now. And lastly, if you need any more information, we have provided some contacts. I do know that in some of the questions people had asked about the questions, they absolutely will be answered and posted. In addition to that, you've asked about resources. We will be posting various resources that we know of on the NCYC webpage under the What Works tab. So definitely be on the lookout. We'll be happy to provide you with more information. And thank you again to everyone who has participated, helped us, and presented today.